Neuromodulator-acquired eyelid ptosis is a dreaded potential side effect for patients and clinicians. Blepharoptosis or eyelid ptosis after injection of neuromodulators has an incidence of about 1% in very experienced providers and about 5% in less experienced providers. In my experience, I would have assumed that number was much lower because of how infrequent I have seen this issue. When an eyelid ptosis does occur, it typically wears off a lot quicker than the treatment itself and can last up to about 4 weeks. Injection technique can reduce the incidence of this occurrence, but it does not eliminate it, and therefore the risk for ptosis needs to be disclosed to patients being treated with neuromodulators. Understanding the anatomy in this area can help us understand the technique that puts patients at lower risk for ptosis. The orbicularis muscle is segmented into 3 parts: the lacrimal, orbital, and palpebral. The frontalis pulls the brows up, and therefore the medial and inferior portion of the frontalis should not be injected to avoid that brow heaviness. The procerus is situated in between the brows, and it starts deep on that nasal bone and attaches more superficially at the level of the frontalis. It pulls the brows downward towards the nose. The corrugator supercilii pulls the eyebrow towards the midline and inferiorly. It can run a little differently in each person, so it's important to look at the patient during expression to inject where the muscle is contracting. The corrugator starts deep medially and attaches to the bone, and then runs laterally where the muscle attaches to the skin. This muscle is responsible for the vertical 11 lines. The corrugator supercilii also overlaps the orbicularis. So at the tail of the corrugator, the orbicularis can also be the muscle that is recruiting. The depressor supercilii is a superficial muscle medial to the orbicularis oculi that pulls the medial portion of the brow downward. The levator palpebrae superioris originates on the sphenoid bone of the orbit and inserts at the skin and the tarsal plate of the eyelid. It is responsible for lifting the eyelid. It's innervated with the ocular motor nerve. The Mueller's muscle arises from the levator palpebrae superioris within the aponeurosis and functions to maintain the elevation of the eyelid. The orbital septum has a few regions that could allow for unintended spread of a neuromodulator. It includes the superior neurovascular pedicles, it has a foramen or a notch, and we've got the supratrochlear, supraorbital, and lacrimal pedicles. The treatment for neuromodulator acquired blepharoptosis was once iopidine 1%, and that was our to-go eye drops for neuromodulator acquired ptosis. Also, antihistamine eye drops such as Nafcon A have also been considered very helpful. More recently, Upneeq came on the market and was FDA approved for ptosis, and therefore the use of Upneeq has become the new standard of practice for eyelid ptosis. It can be applied to stimulate the Mueller's muscle to improve the patient's ability to open the eye. The Upneeq study showed an average of 1 millimeter improvements. In addition, the lateral and medial pretarsal region here of the orbicularis can be injected with a unit of a neuromodulator here and here, or equivalent, to reduce the downward pull of the muscle so the patient's eyelid can open more, and on average a 0.9 millimeter of improvement is noted. After pretarsal injections, if the eye does not close completely at rest, the patient may need to tape the eye closed while sleeping to avoid dryness. There's a case study that was released in 2022 from Saudi Arabia that demonstrated a significant 2 millimeter improvement of neuromodulator acquired ptosis with topical briminodine gel 0.33%, which is typically used for rosacea. However, there are no known studies demonstrating the safety of briminodine eyelids. I personally would wonder if there's potential for causing rebound erythema with use of that medication, but I find that the study was very interesting and I hope it gets further studied. Also, another study mentioned the use of an oral medication called pyridostigmine, which is a muscle strengthener used to treat patients with myasthenia gravis. However, there's limited research available with use of this medication, and there are other side effects that can occur while taking this medication. The best bet for avoiding ptosis is to make sure our injection technique is the safest. This is not considered medical advice, but some of the things that I like to consider in avoiding a ptosis is 1, staying a centimeter above the brow when injecting the glabellar complex. And another one is applying digital pressure with our thumb over that supraorbital rim with our non-injecting hand while injecting that corrugator supercilii. These lateral injections should be superficial as the muscle is attached intradermally. Also, pointing the needle superiorly and away from the orbit when injecting around the glabellar complex or brow region can be helpful. We can also consider a lower dilution rate, so there's a lower risk for spread. To note, a study published in 2021 included 105 patients who received a 3-point glabellar injection technique. It found that a 3-point injection technique was just as efficacious as a 5 or 7-point injection technique, and it has a lower risk for ptosis because it's avoiding those lateral corrugator injections. If you found this information helpful, please like and subscribe for more. If you have anything you'd like me to cover in future videos, please put your requests in the comments below.